Musculoskeletal in sports medicine is actually pretty important because it's 5% of your board questions. But not only that, you're probably going to encounter a pediatric patient, at least one every day, and then right before school, a ton, because you're going to have to do that pre-participation sports physical, right? So it's really important that you know how to assess these patients when they come into your office. With regards to orthopedics, what I'm going to cover is the clinical presentation of the patient with pain. I'd mentioned before inflammatory pain on Monday. Today I'm going to cover mechanical pain, okay? I'm also going to review a little bit about the genetic abnormalities and talk about different pain syndromes and different skeletal muscular conditions ranging from the head and neck down the spine to the upper and lower extremities. Then in my second half of the talk, I'm going to cover sports medicine. So this includes your sports physical, talk about injury prevention, certain conditions and injuries such as heat illness and concussions. And we'll talk about return to play, particularly in today's age where the athlete's very competitive and the parents are even more competitive. So we'll talk about athlete wellness, the female triad athlete with performance-enhancing drugs. What I won't cover is cerebral palsy, muscular dystrophies, osteomyelitis, that's going to be in other sections, osteogenesis imperfecta, and fracture evaluation and management. I really like this quote. This quote says that, unlike adults, a child only realizes his or her difference in relation to others later and does not understand the permanent nature of his or her handicap before puberty. The child's family does everything possible to adapt his or her environment to the disability. So what this quote says is that these children don't even recognize they have a problem. And parents want the best for their children. They want their child to live as normally as they can, so they're going to do everything they can to get this kid on their way, whether or not it's changing their layout in their house or bringing the child to the doctor. So you as a physician, when do you intervene? So you want to intervene if there's growth and developmental issues, if the child failed to meet milestones, if there's organ dysfunction, failure to thrive, or if there's trauma that would affect the above four. Let's look first at congenital torticollis. So in Latin, torticollis means twisted neck, and this is a neck muscle abnormality. It causes the head to tilt. So where the neck muscle is affected, it's usually the sternocleidomastoid or the trapezius, and it contracts. So then the head is tilted back and the chin is in the opposite direction. Typically, it occurs at 2 to 4 weeks of age. Again, the causes, we talked about the sternocleidomastoid or trapezius, but it's related to either traumatic delivery, such as shoulder dystocia or breech presentation, but there also could be cervical spine lesions, such as a tumor or an infection. Sometimes the baby's head in utero could be malpositioned. So these are things to think about in a patient who presents with congenital torticollis. The patient can have facial asymmetry, there's restricted range of motion, and you actually might be able to feel a palpable mass along the neck. The diagnosis is made clinically. Cervical spine films may be indicated, particularly if there's an underlying congenital abnormality. There's a syndrome called Klippel-Feil syndrome. That's where the cervical spine is fused. So that's an indication for x-rays. In patients who have Down syndrome or trisomy 21, you can have atlantoaxial subluxation, so that's another indication for a cervical spine film. But if it's an infant who's born with this condition, you can get an ultrasound, particularly if you suspect maybe an abscess or a tumor or something. You can see that in the sternocleidomastoid. This one, just in this ultrasound, all it shows is a very hypertrophic sternocleidomastoid. It's very thick and large. Most cases are benign and will resolve spontaneously. You would recommend physical therapy. And the goal is to tilt the head away from the affected side, so you're tilting the head back gently. Now, if it persists or they have a lot of pain associated with it, then refer to surgery for release and lengthening of the sternocleidomastoid. Clubfoot. Now, clubfoot definitely requires intervention. You just can't just watch and observe. This is the most common deformity of the lower extremity. It occurs in about 1 in 1,000 children. It's non-painful. The infant won't cry. It's just, they'll have a flexed foot and it's medially rotated. It could be idiopathic or due to a neuromuscular disease, and this is where the ligaments are shortened. So in rheumatology, a lot of things make sense mechanically. So if you're an engineer, you can understand that if the ligaments are shortened, it's going to pull the foot forward. So you would refer patients to physical therapy and definitely have an orthopedic surgeon see them, because sometimes they have to cast this foot or they have to intervene with surgery. Now, patients who do have surgical intervention after surgery, their foot could be half the size of the other foot. In-toeing. Now, this is a benign condition. In-toeing really does not require treatment, and it can occur in 3 different areas. So this is where the toes point inward, okay? If it occurs in the foot, this is called metatarsus adductus. So it makes sense, the metatarsus here, adduct. And this is usually found in infants, and it's due to intrauterine crowding. If it occurs in the tibia, it's called internal tibial torsion. This is the most common form of in-toeing, and usually you see this in 2-year-olds. And then you can have the femur involved, and this is called internal femoral torsion. Usually you see this in 3 to 6-year-olds. And again, it's one of those things that you observe, and you can actually send them to physical therapy if needed. All right, let's start with our first audience response question. Which of the following require orthopedic surgical evaluation when detected? Is it A, in-toeing, B, congenital torticollis, C, clubfoot, D, tibial torsion, or E, femoral torsion? Your answer, please. Excellent. I really wish we had like a pre and post test, like all our questions are in the beginning and let you guys answer it, and then as I go through the lecture, you'll answer it again. You can see how much better you do. Sprengel's deformity. Okay, this is a deformity of the scapula. Think S for Sprengel, S for scapula. And this is where the scapula lifts up. And it's a congenital malposition and dysplasia of the scapula. So the scapula is elevated, adducted, medially and inferiorly rotated. So it just kind of lifts up here. And you can see it on this x-ray. Here's the normal scapula. Here's the scapula that is elevated. There are sporadic cases, but sometimes it could be autosomal dominant in inheritance. And when you see this, you want to evaluate for possible other malformations, such as congenital scoliosis, cervical ribs, Vater syndrome. So that stands for vertebral abnormalities, anal atresia, tracheoesophageal fistula, and renal issues. Klippel-Feil syndrome, which I'll go over later. Physical therapy is required, and then if it's severe, we send them to surgery. All right, I've mentioned Klippel-Feil syndrome. This is the congenital fusion of the cervical vertebra. It's not common, it's about 1 in 40,000 children. And this is where the child has a short neck, and it's almost like their hairline touches their shoulder. And they can't really move their neck very well as well. And it's associated with Sprengel's deformity of the scapula, scoliosis, renal abnormality, and synkinesia. For those of you who don't know what synkinesia is, it's where there's an involuntary action that is induced by a voluntary motion. So if the child smiles, they automatically close their eyes. So it's kind of like a disconjugate of voluntary versus involuntary. Congenital heart defects can also occur, as well as deafness in association with Klippel-Feil syndrome. These patients, you should recommend that they don't participate in contact sports. So it's important when you see a child with this to go ahead and get an imaging of the entire spine and also do a renal ultrasound. Okay, scoliosis. This is going to be really common. You're going to see this in your practice quite frequently. Scoliosis is classified under 3 categories, and it depends on the age when the child is diagnosed. It could be an infantile scoliosis. Usually the onset's under 3 years old. Boys are more affected than girls. It's not very common. And if you see it in the infant, then you have to think about, do they have other underlying abnormalities, such as urinary tract issues or neuromuscular abnormalities? In juveniles, these are in patients who are older or 4 years old or older, and up to 9 years old of age. This occurs in about 12 to 21% of cases. Typically, girls are more afflicted than boys. And the most common form, which we find in greater than 50% of scoliosis, is in the adolescents. And this is typically in ages greater than 10, girls more affected than boys. And you see this up to the point of skeletal maturity. So I'm going to focus on adolescent idiopathic scoliosis. This is where the lateral curvature of the spine is greater than 10 degrees. Okay, that's the definition of scoliosis, is greater than 10 degrees. And it's accompanied by rotation. So 10% of the curves will progress and require intervention. And this is a number here that you need to memorize. Thoracic curves greater than 50% will cause pulmonary compromise. So you can imagine if the curvature is so severe, the patients can't breathe, and they will have a restrictive pattern on their pulmonary function tests. Surgery is indicated in this instance. There's really no clear underlying cause. We do recommend bracing for curves less than 50 degrees, but greater than 25 degrees with certain criteria. So the American Academy of Pediatricians says you really have to screen even if the patient is asymptomatic. So you screen girls at age 10 and at age 12. If it's a boy, you screen either age 13 or age 14. So this is something that you have to remember. Screening for scoliosis for girls is age 10 and age 12, and for boys, either 13 or 14. So this is how you screen. You have them put their hands together and do a diving position. And what you do, I don't know if you use a scoliometer, but if you have a scoliometer and used it before, you take the scoliometer and you push and go down from the top of the spine all the way down. And if there's more of a 5 degrees variance, you go ahead and order an x-ray of the spine. You order the x-ray, basically a full-length PA and lateral view from C7 down to the sacrum, and it also includes the iliac crest. The other thing you need to observe for is whether or not the patient might have like a unilateral rib that's elevated, and you might also see a loin prominence. You order an x-ray if you detect that as well, not just on the scoliometer. So Cobb angle measurement. So the Cobb angle is what we based our treatment decision on, and this is how you measure it. You take the point of the severity of the curve, so the top of it and the bottom of it. You draw a line, and where the line intersects, that's the Cobb angle. Now, if you're a mathematician or love geometry, my daughter's starting geometry, so you go ahead and you can calculate other angles if you want, but you can draw a perpendicular angle right here and right here. Where it intersects, these two angles are congruent. Love that word, congruent. So, all right. Girls are more likely to progress, and girls who have a lot of growth potential and they grow very quickly, they're more likely to progress. And this is measured by the sexual maturity rate, okay? Also, the degree of the curvature at the time of diagnosis, the more severe the degree of curvature, those are also have a higher likelihood to progress. So talking about treatment, for sure, 100%, you go ahead and do bracing at 30 degrees or higher, but surgery is indicated at greater than 50 degrees, okay? You can also do surgery at 40 to 50 degrees if patient have a lot of pain or if there's some pulmonary compromise. If we're bracing, these are the different types of braces that can be used, and I'll go into that in further detail. Now, the thing about bracing is it doesn't really correct the scoliosis, but it can prevent it from getting worse. So also another thing to remember is that once the patient hits skeletal maturity, and if their curves is under 40 degrees, then you don't really have to worry too much about them unless they have significant pain, in which case you want to find a scoliosis surgeon and refer them. All right, so what about the rules for bracing? There's certain gray zones, like do you brace, do you not brace? So think about the Cobb angle of 25 degrees. If the Cobb angle is equal or greater than 25 degrees and the patient still has a lot of growth left until skeletal maturity, go ahead and brace. If the Cobb angle is less than 25 degrees, but there's a rapid progression at the 4 to 6 months follow-up of at least 5 degrees, you go ahead and brace. It's recommended that these braces are worn for at least 18 hours a day, all right? So compliance and adherence to bracing is really tough when you're in adolescence because these braces are uncomfortable. So the braces should be worn until the end of the vertebral bone growth, at which time you taper the bracing down to allow for their skeletal muscle and core muscles to strengthen. Now, there was a meta-analysis that was published that showed that kids who are in braces for 23 hours or more, they actually do a whole lot better compared to children who are in their braces for 18 hours or less. Associated findings of scoliosis, you might see McCune-Albright syndrome. This is where these patients have precocious puberty, café au lait spots. These are buzzwords, by the way. Marfan syndrome, where their arm span is greater than their height. I've shown you a case of that in my last lecture. Sometimes these patients can have lens dislocation and mitral valve prolapse. Ehlers-Danlos syndrome, excessive joint laxity, as well as POTS, postural orthostatic tachycardia syndrome, can be associated with EDS. Neurofibromatosis, these are patients with café au lait spot and axillary freckling. And then spinal dysraphism. This is basically where the spinal cord is tethered to the vertebra. And you can see hyper or hypopigmented lesions over the spine and a patch of hair growing over the spine. All right, let's look at kyphosis. This is where there's abnormal AP curvature of the spine. In my first lecture, I showed you an example. This is a most severe kind of kyphosis, which is Schuermann's kyphosis. It's more common in males, and this is typically during the prepubertal growth spurt. And it's related to having anterior wedging of 3 contiguous thoracic vertebrae of greater than 5 degrees. So it's almost like a compression fracture. And we see these in kids who are growing really fast. They're doing a lot of heavy weightlifting or something that put a lot of pressure on the spine. And so on x-rays, that's how we diagnose it, because there's an abnormal growth plate for them. And actually, if you look on this x-ray, you can see the anterior wedging on these vertebrae. All right, pectus excavatum versus pectus carinatum. So excavatum is where there's depression of the midsternum. You can see this in patients who have Marfan's disease or Ehlers-Danlos syndrome. Spirometry is normal except when it's severe, and I've seen sparingly very severe cases where almost the sternum touches the spine, and it can cause cardiopulmonary dysfunction. And carinatum, pectus carinatum, this is where these patients are pigeon-chested. They're rarely asymptomatic, we really don't do much. I mean, if they're very bothered by it, you can have them see a thoracic surgeon. The next is asphyxiating thoracic dystrophy. This is Jeune syndrome. This is an autosomal recessive disease. It's a disorder of bone growth. It's not common at all. 1 in 100,000 patients. The patients have very shortened ribs and a small rib cage, and because of the small rib cage, the lungs can't expand. So these patients may have some respiratory compromise, and they'll have to be intubated, and ventilatory support is needed in severe cases. Sometimes they'll have polydactyly. You'll see basically 6 fingers or 7 fingers with or without the bone inside. Some patients can also have liver disease. All right, let's look at our next question. 13-year-old girl, she has a 27-degree scoliosis. It's progressed by 8% in the last 6 months. Which of the following is advisable? Do you prescribe physical therapy and traction, reassess in 2 months? Should you make her wear a brace for at least 18 hours a day until she reaches skeletal maturity? Do you send her to a surgeon because of rapid progression? Do you prescribe NSAIDs, reassure, and say, hey, don't worry about it, I'll see you in a year? Or do you go ahead and brace for 8 to 12 hours because it provides as much benefits as 23 hours of bracing? So your answer, please. Correct. The answer is B. So this patient has over 25 degrees, and also it's progressed at least 5%, so she progressed at 8%, so she needs to wear a brace for at least 18 hours a day, if possible 23 hours a day. Surgery is indicated if it's greater than 50 degrees or 40 degrees if there's significant pain or pulmonary compromise. And these other answers are not correct. The bracing at 8 to 12 hours really don't do much, and the benefits of 23 hours is the best. All right, clicks. You're going to hear a lot of clicks, okay, in children. And clicks is just basically these small little clicky noises, and typically they're benign. Its relationship is to the stretching and snapping of the joint capsule and the tendon. Typically, they'll resolve by 2 to 3 weeks. We really don't do much about them. But there are instances when the click really is a clunk. Now, clunks we worry about. And this is in developmental dysplasia of the hip. This is where the femoral head do not align correctly to the acetabulum. In the first image, this is normal. And developmental dysplasia of the hip can occur in varying degrees where it can completely separate from the acetabulum. It's found in about 1.5% of neonates, so this is a common condition. You need a test for it. And it affects the femur and the acetabulum. If the femur does not come in contact with the acetabulum, then there's going to be abnormal development. And long-term, these patients are going to develop osteoarthritis, issues with their spine and their gait. So I have a patient who's 27, and she had to have a total hip replacement because she wasn't treated correctly as a child. All right, what are the risk factors for DDH? Being female. Being female is a huge risk factor. Part of that is because of the relaxin hormone from the mom. But if a child also has a family history of DDH in a parent, the risk is 12%, in a sibling it's 6%, or if the child has a breech presentation. So these are all major risk factors for DDH. There are minor risk factors, and this includes multiple gestation, first pregnancy, high birth weight, lack of or decreased amniotic fluid, and other musculoskeletal disorders. So it's important to screen at birth, and for infants under the age of 12 weeks, typically 8 to 10 weeks, we screen basically at their every well visit, 2 weeks at birth and so on. And the two tests you are very familiar with is Barlow and Ortlani. So the Barlow test that's where you apply pressure to the knee and you adduct the leg in, and you hear a clunk as the femoral head moves out of the acetabulum. So you bring the leg out, in, and it pops out. The Ortlani maneuver is basically you're bringing the femoral head back in, so you'll hear a second clunk, so you abduct, you pull the leg up and move it out. So what about infants over the age of 3 months old? The Barlow and Ortlani test really isn't that sensitive to pick up DDH, so you have to look at the child. There may be leg length discrepancy, but also you may see that the child's standing up an asymmetry in the gluteal folds. The affected leg is usually lower. And there's also Galeazzi and Klisik's tests, and these are better indicators for DDH in a child who's greater than 3 months old. So let's talk about the Galeazzi sign. This is where you want the infant to be lying down, you flex their hip, you flex their knee, and you want to make sure their feet are aligned properly. And this is where there's an unequal knee length. The knee that's shorter is the hip that's affected. Now, what happens if the patient has bilateral DDH, right? So both knees are low, so how are you going to detect that? So one of the things that you can do is look for the Klisik sign. And so what you do is you put your forefinger right on the superior anterior iliac spine, and then you put the second finger, your middle finger, on the greater trochanter. And the line, imaginary line, should really fall right at the umbilicus. But if it follows below the umbilicus, then that's a positive test for Klisik. In walking age children, so these are children who are at, about 2 years old, these children can present with unilateral DDH, and the hip adductors are weak. They could be atrophic. So when you ask them to stand on one leg, you'll find that there's a pelvic tilt. So that's a positive Trendelenburg test. If there's a pelvic tilt, that's a positive test for DDH, and in which case you want to go ahead and get the x-ray of the pelvis and hip. All right, which of the following is the best indicator for developmental dysplasia of the hip when assessing a 3-day-old baby? 3-day-old. A clunk is heard when the hip is flexed and adducted, and another clunk is heard when the hip is abducted. B, with the hip and knees flexed and the feet flat, the ipsilateral knee is lower. C, asymmetrical gluteal folds. D, asymmetrical leg length. Or E, the pelvis is tilted when the baby is held up. Your answer, please. It's correct. That's the Barlow-Ortlani sign. This is Galeazzi sign, the asymmetrical gluteal folds for children over the age of 12 weeks, asymmetrical leg length in patients over the age of 12 weeks, and the pelvis tilt is the Trendelenburg for walking age children. All right, when do you refer? You refer to an orthopedic surgeon. It's important that they get early intervention because, or else they'll have leg length discrepancy and osteoarthritis later on in life. So if the results are positive on any screening maneuver, you go ahead and refer. We also recommend imaging. So for infants, you can't really see calcification of the epiphysis or the femoral head, so it's important to get an ultrasound instead. Triple diapering, that's what they used to do. It's no longer recommended because the position is to have the legs abducted, kind of like in a frog-like position to bring the femoral head in. So if the exam is equivocal, go ahead and repeat the exam in 2 weeks. If it's still equivocal, go ahead and refer and get imaging. So I'd mentioned before, ultrasound is recommended if the child is young, under the age of 6 months. And then go ahead and obtain an ultrasound if there's any questionable examination, or if the child is in a breech position after age 34 weeks of gestation. In a female at 4 to 6 weeks, that's when you get the ultrasound. And then in a male, so any boys with breech position over the age of 46 weeks, you have to consider an ultrasound, or a family history of hip dysplasia, consider an ultrasound. So this is consideration. This is without a doubt. You go ahead and get an ultrasound in girls. So in terms of the imaging, this is an x-ray. You can actually see a little calcification here, but you can understand, you don't see the cartilage on x-rays if the child's under 6 months old. So the goal is to reduce or restore the femoral head and maintain the contact to the acetabulum. So this is what the orthopedic surgeon will do. He'll put the child in a Pavlik harness. Looks like bungee jumping, right? So shoulder straps, chest strap, and legs, and it keeps the legs abducted. Complications, early osteoarthritis. These patients can also develop osteonecrosis of the femoral head, and also hip instability. All right, 3-day-old male. You have a left hip click during abduction. Right hip, remainder of the exam is normal. Family history is unremarkable for hip dysplasia. And his delivery is unremarkable. Presentation's not breech. What do you do? Go ahead and triple diaper him for a month and then re-examine, refer him to an orthopedic surgeon, go ahead and get x-rays of the hip. Or do you do an ultrasound of the hip because he's under 6 months? Or no imaging is required, just re-examine him in 2 weeks. Your answer, please. Exactly. You just reassure the parent and just re-examine them in 2 weeks. All right. So this is physiologic genu varus. We're talking about knock-kneed or bow-leggedness, right? So the way you tell the difference between varus deformity versus valgus deformity is you look at the joint and you look at the distal part of the joint. Varus is where it points medially in, and valgus is where it points out. Okay, so genu varus, which looks like a bow-leggedness, can occur up to 2 years of age. And then physiological development is that these children will develop a genu valgum at 3 to 6 years old, and by 7 years old, they correct themselves. So you need to know this because Blount disease, which is where these children can have unilateral or bilateral varus deformities can occur, and sometimes surgical intervention is needed. So this is Blount disease. And you can see this is the unilateral version. This is the bilateral version. So think about Blount like mount a horse. And so when you mount a horse, you can become bow-legged, right? So the infantile form is under 4 years old. Typically it's bilateral. In the adolescent form, typically it's unilateral and can occur with obesity. Risk factors here is early walking, African American ethnicity, I'd mentioned obesity before, but also being a female. The thing about this is that if patients have severe disease, they require bracing. Sometimes they require surgical intervention to straighten the legs. And the surgeon will do an osteotomy and internal fixation, or they, for severe cases, maybe an external fixation. But patients usually have a very good outcome. Benign limb pain, formerly known as growing pains, but they're not really due to growing. It occurs in 10 to 20% of school-aged children. There's some psychological stressors that are associated with these benign limb pains. We see them in patients who are 8 to 12 years old. It's the most common cause of skeletal muscular complaints in children. Typically, they're bilateral. These children will have a deep ache in their thighs, their calves, popliteal fossa. They can wake up from sleep, and typically it occurs at night. There's no joint involvement, no inflammation. Exam is completely normal, and really we don't intervene much. We tell the parents massage their legs, try some acetaminophen or NSAIDs, and typically it goes away. But you got to remember the red flags. So red flags are those conditions that can cause significant disability, so malignancy, trauma, osteomyelitis. And so you want to get a really good history, make sure these patients are not having fever, weight loss, malaise, that the exam doesn't show any weakness or atrophy or swelling. Now, if they lose developmental milestones, you definitely want to explore this issue further. And if the pain syndrome does not respond to acetaminophen or ibuprofen conservative measure, that's also a red flag. So I talked about the differential diagnosis of the limb pain. So stress fractures can occur, but also these type of tumors in the legs can also occur as well, and I'll go through a few of those. So this is toddler's fracture or cast fractures, childhood accidental spiral tibial fractures. So these are minimally displaced. You'll see like a late lucency, and it comes around. There's tender to palpation. The patient will complain of pain. And usually, if you can treat this by putting a patient in a cast, but typically the CAM boot is all you needed. CAM boot stands for Controlled Ankle Motion Boot. And they did a study, a retrospective cohort study of 600 children where 61% had a visible fracture. And they found that if you place the patient in the CAM boot, they actually return to weight bearing a lot sooner compared to patients who are in a cast. And the x-rays really didn't affect management. This is an osteoid osteoma. They're round, lucent, sclerotic lesions, and they have a nidus in the middle. These are benign lesions, except for the fact that they produce prostaglandins. So the prostaglandin production typically also occurs at night. If you give a patient aspirin or NSAIDs, the symptoms improve because those are prostaglandin inhibitors. Usually it's found in the proximal femur or the tibia, and the x-ray will show the lesion. You go ahead and repeat the x-ray every 4 to 6 months until the patient's asymptomatic or the lesion resolves, and typically it can resolve in about a few years. Now, for severe cases where the patient's complaining of a lot of pain or the lesion is a bit large, then sometimes we do refer these patients for radiofrequency ablation or to surgery for resection. Now, this is in contrast to an osteoid osteoblastoma. Basically, it's huge, at least 2 centimeters in diameter. The lesion will grow, and they grow rapidly and destroy the bone. Sometimes you'll even feel a soft tissue mass. So blastoma, think about it, just blast right through. The pain's not relieved by aspirin or NSAIDs, and you really have to send them to surgery in order to do a curettage because pathologic fractures can occur. Next, you have the non-ossifying fibroma. These are like bubble wraps. They have a lot of little bubbles inside whenever you do the x-ray. And there's 2 types. One is unicameral, which means that it's fluid-filled, and then the other one is aneurysmal, where it's filled with blood. Typically, we see these in children at 5 to 15 years of age, and they are asymptomatic. And they're usually picked up incidentally when you're doing an x-ray of something else. The lesions typically will become sclerotic. We don't intervene unless it's really large or if there's a pathologic fracture. All right, what about the limping child? The most common diagnosis for transient synovitis is actually related to a viral illness. This is where there's inflammation, swelling. Typically, it's in the hip, and patients will have problems with abduction or external rotation, and they'll walk with a painful limp. When you do an x-ray, you'll see widening of the joint space. If you do an ultrasound, you see a hip effusion. You got to be careful because sometimes these patients actually have a septic arthritis. For patients with transient synovitis, we manage them with NSAIDs. And then I talked about septic arthritis in my first lecture, but these patients, they're very irritable, they have fever, they really don't want to even walk. And if you do labs, you're going to see elevated sed-rate CRP, elevated white counts and platelets. The most common cause of septic arthritis in children is actually staph. For patients with heel and foot pain, most are due to trauma. These are cuts, punctures, and contusions. Get an x-ray if you see a puncture wound, because sometimes you'll see a radiopaque object. Sometimes ultrasound is needed if persistent pain for radiolucent objects. And differential diagnosis here is infection, tendinitis, or tendon rupture. Ultrasound will show tendon rupture. X-ray won't show soft tissue manifestations. Sever disease, this is the most common cause of heel pain, particularly in a child who plays sports. This occurs with running, jumping, so you see this in soccer, basketball. This is inflammation around the calcaneal growth plate, and it's where the Achilles tendon inserts. So it's an apophysitis. When you touch the heel, the patient will be hurting and they'll pull back or cry. Treat it with rest, ice, stretching, use a heel cup. Usually we tell patients to not participate in the sports until it gets better. Then we have traumatic myositis ossificans. This is typically a benign lesion, calcification following trauma, and it can present as an enlarging mass, typically in adolescence. And on x-ray, you'll see ossification with a distinct margin. Now, these should be distinguished from basically sarcoma related to the bone and soft tissue. And the reason why this is not a sarcoma is because there's no connection here to the bone. And we usually do not like to send these patients to surgery because surgery causes trauma, and guess what? It calcifies some more. So here's the case. 3-year-old boy brought for evaluation. He was limping. An exam noted tenderness to the left lower tibia. X-ray of the leg is shown. See where the arrow is. What of the following should be done? Do you call CPS, Child Protective Services, report child abuse because of that fracture? Do you prescribe NSAIDs because it's an osteoid osteoma? Do you get a CT scan to make sure that, what if there's something else going on? Do you place the child in a CAM boot, follow up in a month? Or do you evaluate for an underlying metabolic disease? D is the correct answer. That was basically a cast fracture, a toddler's fracture. So the evaluation for the sports participation, I'm sure many of you are glad that you're here and not at home trying to get kids ready for school because you get stacks and stacks of sports physical papers that you have to fill out. But the goal for the pre-participation evaluation is to promote the health and safety of the athlete. And we also want to identify conditions that can carry life-threatening risk during participation, and it might require a treatment plan before you can allow them to play. So part of the sports participation evaluation includes going over their health history, trying to figure out whether or not they've had prior injuries, a family history of cardiovascular health. If you go to www.aap.org, so this is the American Academy of Pediatrics website, it has a whole form for you that you can fill out and then give to the patient who's in for the sports physical. So the key thing here is that if there are patients with abnormal cardiopulmonary signs or symptoms, you want to refer them on to a cardiologist for further testing. And this can include labs, EKG, or an echo. Now, many schools are very conscientious about concussion testing, and they'll do a baseline pre-injury concussion testing at the school. But if the school doesn't do it, it's going to be up to you to have some kind of plan in place for this. And then the American Heart Association currently, they do not recommend getting an EKG on everybody, nor doing routine labs. for a pre-participation evaluation. Now, if you're going to get labs for their routine physical, go ahead and do it, but specifically for sports participation, you do not. So these are conditions that are life-threatening, and sometimes you'll have to exclude the child from play. This includes hypertrophic cardiomyopathy, so know what the murmur of HOCM sounds like, okay? Go and review your cardiology section. Patients who have prolonged QT intervals, aortic stenosis, coronary artery anomalies, these patients should be restricted, as well as those who have myocarditis or uncontrolled is the key here, stage 2 hypertension, fever, active fever because of the risk for heat-related illnesses, and patients who still have symptomatic concussions. These patients should sit out. Now, there are conditions that will require an action plan. So the child could still participate. However, you have to come up with a plan so that they won't be injured, or if they're injured, what to do about it. And this includes asthma, hypertension, diabetes, eating disorders, skeletal muscular injuries or disorders, as well as concussions. The thing about concussions is, there are people that have this common belief, 3 strikes, you're out, 3 concussions, no more play. Well, that's not really a magic number, and it's not really endorsed anywhere. In fact, if you tell the child 3 concussions, you're out, the child's going to lie to you. The child's going to lie to their parents, to their coaches, because these kids really want to play. They don't want to let their teams down. So the best thing to do is you say, if you have an injury, let us know. If you have a concussion, we're going to put you out, but we're going to reassess you, make sure things are okay. And if everything's good, then we can go ahead and put you into play, possibly not in that position. So the 3 strikes you're out really is not what we endorse. All right, so there are special considerations in these patient population. Patients with trisomy 21 or Down syndrome, you have to look for atlantoaxial instability, so that's C1, C2. Sometimes C1, C2 can sublux, and then it can cause a lot of neurologic issues. So you have to be careful in patients who have Down syndrome wanting to play football. Seizure disorders. Well, this makes a lot of sense. You don't want a child to have an active seizure doing an activity that could be life-threatening, like free climbing, hang gliding, scuba diving, because having a seizure in the midst of one of these activities could be life-threatening. Patients with type 1 diabetes, you want to monitor their glucose before, during, and after exercise. And then patients with Marfan syndrome, avoid contact sports because of the risk for cardiovascular bleeding, lens dislocation, and pneumothoraces. So the American Academy of Pediatrics came out in 2016, a sports injury prevention tips sheet. You can go to their website and print this out, hand it to every child who's about to participate in sport. Because these children, nowadays they think they know everything, but sometimes it has to be written down. So first of all, you gotta take time off, about 1 day a week. Wear the right gear. If they're bicycling, you gotta wear a helmet. If they're playing catcher, you have to make sure they have a face mask. Strengthen the muscle, increase flexibility, use proper technique. Somebody who's a tennis player, if you don't, you're gonna have sports injuries. Take breaks, play it safe. Basically, rules are there for a reason. And if there's activity, it's okay to say, hey, I wanna take a break. And just emphasize that to the child that you don't have to push on if there's pain. And the biggest thing here is avoid heat injury. These children, particularly in Texas, they get overheated very quickly in the summer, particularly with practice occurring in the late afternoons, so it's important to hydrate frequently. So heat illness is where the body cannot cool off. And there are several risk factors associated with this, including being young, if they have an underlying illness, so such as diabetes or hypertension, being overweight, if there's alcohol consumption. This is something you need to screen for in our teenagers. Certain medications, such as medications for ADD and ADHD, these stimulants can actually overheat the body as well. Hot, humid weather, strenuous activity, as well as poor hydration. There's 3 levels of heat illnesses. The first one's the mildest. It's called heat cramps. These patients can have muscle cramps, and it occurs during exercise. And usually, if you stop the activity, you tell them to hydrate, and then you give them electrolyte repletion, they're usually fine, okay? And electrolyte repletion, it could be those sports drinks that are out there. The problem is that there are many parents who give sports drinks to children even when they're not exercising, so that's one of the reasons why the obesity level does go up and rates of diabetes goes up. Next, heat exhaustion. This is where the body temperature exceeds 102 degrees, but is under 104 degrees. These patients will present with tachycardia, profuse sweating, weakness. There's no neurological symptoms with heat exhaustion. The key thing here is you got to move the patient into a cool place. You got to rapidly cool them. So this could be ice baths, ice packs, fluids, remove their clothing if necessary. Then heat stroke. Heat stroke, it's life-threatening. This is where the body temperature is greater than 104 degrees. These patients will have neurologic symptoms. They could have slurred speech, they can have seizures, they can have double vision. So it's a medical emergency. You got to measure the temperature by a rectal temperature. One of the most common causes of childhood heat-related deaths isn't from sports. It's actually leaving the child in the car. So it's one of those things that it's under-recognized, and I think we as physicians have a responsibility to make sure that our children are safe. So they did a study, and what they did was they took a light sedan, they put it in the environment that's about 78 degrees for 1 hour. The temperature rose up to 104 degrees. That's a light sedan, outside temperature 78 degrees. In a dark color sedan, the temperature rose up to above 110 degrees. And death occurs at 107 degrees. All right? So even with cooler outside temperatures, you just can't leave a child in a car. And you counsel the patient's mom that even if the car is parked outside, make sure the doors, nobody's inside, the doors are locked, because sometimes kids like to play hide and seek. They get in, but they can't get out. So that's also another thing to be conscious of. All right, so here's a question. Patients with which of the following conditions should avoid playing high-impact or vigorous sports? Is it A, asthma, B, Down syndrome, C, diabetes, D, history of 2 or more concussions, or E, prolonged QT? Your answer, please. The answer is actually prolonged QT syndrome. We don't restrict patients from playing with asthma or Down syndrome. As long as you have an action plan, you make sure that lentil axial joint is okay. Diabetes, as long as you have a plan to monitor their glucose, and history of 2 or more concussions, you still can play as long as the patient's neurologically intact. So prolonged QT, definitely not. All right, let's look at the limping child. This is school-aged children. Previously, I talked to you about children who are like toddlers and younger. So now I'm going to turn your attention to the kind of injuries we see in school age and adolescents. So leg calves Perthes disease is where there's idiopathic osteonecrosis or avascular necrosis of the femoral head. And this is where there's interruption of the vascular supply to the femoral head. And the peak incidence is about 5 to 7 years, but it can occur up to 10 years old, most often in boys. 90% of cases are unilateral. And so the patient presents with hip pain. Now, true hip pain is down the groin. All right, lateral side of the hip, that's more like a bursitis or a tendinitis or IT band syndrome, but true hip pain is down the groin, anterior thigh. So these patients will have problems with external rotation, abduction of the hip. And remember, mechanical pain is worse in the afternoon and worse with activity, so this is a mechanical issue. And so with regards to the risk factors for Legg-Calvé-Perthes disease, sickle cell anemia, because when these patients have a crisis, the sickle cells could actually get clogged into the artery and cause the avascular necrosis. Glucocorticoids, also notorious for AVNs, as well as patients who have renal failures. So the way you diagnose this is you go ahead and get an AP X-ray, frog leg position. And what you'll see here is you can see an irregularity and increased density in the femoral head. There may also be epiphyseal fragmentation as well. In the early stages, the X-rays is normal, but if you have a high suspicion, go ahead and get a bone scan or an MRI. So the goal of treatment, is to preserve the femoral head and to preserve the range of motion of the hip. Because if you don't, then what ends up happening is these children end up developing osteoarthritis and then needing a hip replacement earlier in life. The non-operative management of this, if it's mild, is having them either brace, or you can do bed rest traction, some physical therapy, NSAIDs for pain, and protected weight bearing. You really don't want these patients to go out and start running and doing really heavy duty sports. Now, if the symptoms are severe or if the x-ray shows pretty moderate disease, you need to go ahead and have them see a surgical specialist, because osteotomy can actually hasten femoral remodeling. Okay, which one of the following is associated with an increased risk of avascular necrosis of the femoral head? Is it A, sickle cell disease, B, ulcerative colitis, C, cystic fibrosis, D, hypercoagulability disorders, or E, neurofibromatosis type 1? That's correct. Answer is A, sickle cell disease. There's been a few cases reported of a hypocoagulable disorder that can cause AVN, but if you were to see something like this on the board question, you want to go for the most common answers. All right, what about SCFE? Slip capital femoral epiphysis. This is basically where the top part of the femoral head slips off of the epiphysis. It's the most common hip disorder of adolescence, and it requires surgical intervention. Without surgical intervention, these children will continue to limp, and then their bone will not remodel correctly. It's most common during the growth spurts of younger adolescents. So in girls, it's about 11 to 13 years old, kind of like the time they start their periods, and in boys, 12 to 14 years old. And the buzzword is basically an ice cream cone slipping off of its cone. Risk factors are African Americans, obesity, and also patients who have endocrine dysfunction, such as hypothyroidism or growth hormone deficiency. Now, these patients, because it does involve the hip, same thing. You're going to have pain in the anterior thigh down the groin. You can also have knee pain, thigh pain, and patients will walk with an antalgic gait. They're going to try and protect that hip. So they're going to be shuffling a little bit, they're going to be limping. And again, this is a mechanical issue, so you're going to see pain is worse with activity and improves with rest. In about 20 to 40% of patients, the disease will be bilateral. And in patients who have unilateral disease, about 30 to 60% of patients will progress on to bilateral disease. Usually they'll present unilateral and then they go on. There could be severe slippage that will then cause avascular necrosis as well. And the diagnosis here is just simple x-rays. You take an x-ray and you try to see whether or not the top of the femur is slipped off of the femoral epiphysis. On MRI, you can see surrounding edema because there's irritation and inflammatory response to it. So I mentioned that this requires immediate surgical intervention. Osgood-Schlatters disease. This is actually very common, particularly common in patients who have to squat a lot or who goes up into a jumping position. So you're thinking about baseball catchers, you're thinking about basketball players, repetitive stress and injury. And what happens is that the patellar tendon basically dislodges from the tibial tuberosity. This is where it attaches. And so this is a traction apophysitis related to it. And sometimes it does separate completely. So this occurs during the adolescence growth spurt. Typically it's asymmetric, but you can see it bilaterally in about 25 to 50% of cases. And again, I'd mentioned basketball player, gymnasts, patients who run, play football, volleyball, anything that contracts the quadriceps and springs back up again. So the way you diagnose this is you just push on it. And they have a big lump right below the kneecap when they're sitting down, and if it's tender, that's generally Osgood-Schlatters disease. It's typically benign. You try to avoid the activity that's causing the insult. Patients may have limited knee flexion as well. So the exam is actually a clinical exam, and usually we don't obtain x-rays, not unless there's atypical complaints like redness, fluctuance, that makes you want to think about infection. So some patients may require a protective pad over the tibial tuberosity, and you just basically ice, rest, elevation, NSAIDs. Patellofemoral syndrome is pretty common, and this is where the patella rubs against the femur. That's why they call it patellofemoral. Typically, we have a child who's in a lot of pain, particularly when they go up and down the stairs, because that's when you use the flexion extension maneuvers that bends the knee and then causes the patella to rub. So we see this more so in girls compared to boys. We see it in runners, cyclists. And on exam, there's two ways you can test for this. You have the patient lie down, and you push directly on the patella, kind of making it rub against the femur. If it elicits pain, that's a positive test. The second way you do this is you go around the patella, you feel into the facet area. These patients really don't like you to move their patella. And so if it causes pain, again, that's a positive test. And treatment is conservative, primarily quadricep strengthening exercises. We send these patients to physical therapy and avoid the underlying activity that could aggravate it until they're better. The iliotibial bend syndrome, ITB bend. So this is where the bend goes from the iliac crest and it runs all the way down to the tibia. I mean, in the world of rheumatology, the names really make sense. Ilio down to the tibia. And this is where there's pain right over the insertion site of the proximal tibia to the knee. And what happens is that this band can be tight, and so it rubs, causes friction between the IT band and the lateral femoral condyle. So we see this in runners, we see these in cyclists, soccer players, where there's a lot of repetitive motion and intensity. And so the way you determine whether or not somebody has IT band syndrome is you have them lay down, lateral decubitus position, their hips a little bit flexed, their knees a little bit flexed, and then you push down along the aspects of the IT band, and they'll feel a lot of pain around the lateral tibia. So again, conservative management of this condition. Sometimes they do respond to steroid injections. All right. Pain associated with Osgood-Schlatters disease is typically located in which of the following areas? A, is it the iliac crest? B, the lateral thigh, C, the groin, D, tibial tuberosity, or E, medial side of the knee. The answer is D, tibial tuberosity. Osgood-Schlatters disease is where there's avulsion or basically strain along the patellar tendon on the tibial tuberosity. Iliac crest, we tend to think about the IT band, same with lateral thigh. Groin, we think about SCFE, or we think about leg cavity disease, where there's the hit. The medial side of the knee, you think about medial collateral ligament or medial meniscus. And let's move on. So there's a lot of involvement with baseball. It's America's sport, right? So they start off young, and so when they start off young and they don't have proper throwing technique, we have something called Little League elbow. This is a medial elbow epiphysitis, and it's kind of like golfer's elbow in adults. So that's medial epicondylitis. And what happens is these patients, when they reach back and throw, instead of throwing forward like this, they make a swing, like an arc. And so they end up injuring their medial elbow, and the popliteal site right here can actually avulse. There's pain in the medial elbow, and the treatment here is that you have to tell them to rest, give them NSAIDs, ice it, and then physical therapy to stabilize their scapula and show them the proper throwing techniques. Now, the opposite of that is lateral epicondylitis. So instead of the medial side, it's on the lateral side. And this is what we call tennis elbow. And this is related to backhand. So whenever you do a backhand swing like this, instead of moving your whole arm through, these kids are just going like this. So we see it in racquetball players as well. So it's an overuse injury. And basically, there's pain right at the lateral epicondyle. And the way you provoke this, where it's a positive test, is you have the patient do a resisted extension of the wrist and the fingers, and it'll bring on pain right here. Tennis elbow splints, they help because they prevent the kid from going like this. Instead, they're going to make the child do the full motion of the backhand. Again, it's about proper technique, rest, ice, brace. Sometimes it's very tenacious. The issue here is back then we used to inject for tennis elbow. We don't do that anymore because they did a study looking at injection versus physical therapy. After about 8 weeks, they find that patients who do not have an injection actually recover faster. In fact, steroid injections can prolong the illness. Osteochondritis dissecans. This is actually pretty fun because we call it joint mice. And the reason why is because you see these small little subchondral bone, and they just look like little tiny mice around there when you do an x-ray. And it's usually from repetitive trauma, although you can see it in a single injury. Typically, you see this in boys, 8 to 18 years old. The common site here is the knee, but you can also see it in the elbow and the ankle. And these symptoms that the boys have is joint locking, popping, decreased range of motion. And when you do the x-ray, you see these small little loose bodies. The key thing is sometimes you can manage it conservatively, but if the pain persists or function is affected, you go ahead and get an orthopedic referral because they may have to remove some of these loose bodies. Okay, spondylolysis. Okay, so you hear of the term spondylosis. That just means degenerative joint disease. Spondylolysis is basically where there's stress fracture of the vertebral pars. This is actually a fracture. It's usually in athletes that do a lot of hyperextension with a lot of pressure down. So you're thinking about gymnasts, you're thinking about weightlifters, sometimes football players when they reach back and they put a lot of force back. So it's most common between the ages of 10 and 15 years old. And again, these are the people who are at risk, ballet dancer and wrestlers as well. So the clinical presentation is that these children will present with low back pain, and it's a mechanical pain. It's worse in the afternoon and worse with activity. And the pain also increases when the patient's bending backwards. They're going to aggravate that area of the fracture. And it also increases when the patient is standing and you're doing a straight leg raise. So it forces the hyperextension of the back to keep their balance. There'll be hamstring tightness, and there may or may not be tenderness to direct palpation of vertebral pars. The exam typically is normal. I mean, you're not going to have leg atrophy or weakness. If you do, you need to think about some other diagnosis. So this is the x-ray. Typically, it's the 5th vertebra. And think about the Scotty dog. So here's the ear of the dog, here's the nose, and here's the body. Well, it's the collar on the dog. If you see a lucency right at the collar, here's another dog down here, but there's no lucency here. So if you see a lucency, that's the fracture of the vertebral pars. So many times these children will come and it's after some kind of sports practice and they're misdiagnosed as having a lumbar strain. So just keep that in mind. Now, spondylolysis is totally different from spondylolisthesis, all right? Listhesis is basically when the vertebral body on top slides forward and the vertebral body on the bottom slides backward. So it's kind of like a shift in the alignment of the spine. And spondylolisthesis can cause spasming in the back and stiffens their back. A lot of older people, many of the faculty of med study will have spondylolisthesis, especially standing up here for a while. And so the hamstrings could be tightened. It limits the ability to raise your leg straight. And sometimes if you go down the spine of the child, you'll actually feel a step off. It just goes down and goes in. And so these patients can have an exaggerated lordosis where they hyperextend their back. Now, this is the signs of neurologic emergency, is if they have bladder or bowel incontinence, because if they slip their vertebral bodies enough, their spinal cord can be impinged and also the nerve roots, so they could have cauda equina syndrome. And so this would be a surgical issue if they have incontinence. Sometimes they have symptoms that mimic sciatica, where there'll be radiation of the nerve down the posterior knee. And again, this is a mechanical pain. If you look at the x-ray on the lateral view, you'll see that there's this anterior displacement of the L5 relative to S1. Spondylolisthesis management is observation until the growth is complete. And you want them to strengthen their core exercise. Physical therapy, water therapy works very well. You also want them to strengthen their hamstrings. So, and avoid activities that actually might aggravate symptoms. Rarely, you do use some bracing or other orthotics to control pain. And again, neurological evaluation. If there's signs and symptoms of neurologic compromise, send them to surgery. All right. Stress fracture of the vertebral pars, spondylolysis, are most commonly associated with which of the following activities? Is it baseball, volleyball, swimming, gymnastics, or soccer? Excellent. Gymnastics because of the hyperextension. The way the boards will probably ask the question is that they'll say this is a 10-year-old girl, she's a gymnast, and then she presented with back pain after doing 2 back handsprings. What is she at risk for? And then it'll say vertebral pars fracture, strain, or something else. So it's just one way of approaching it. All right, sprains, strains. So sprain is where there's a tear of a ligament. Strain is where there's tear of muscles or tendons. And so the signs and symptoms, you'll have ecchymoses, swelling, tenderness to palpation. You can do x-rays, but typically they're normal. You might see a separation, if it's an ankle sprain, separation of the talar tibial ligament, the triangular ligament. And then you might consider doing an ultrasound or MRI to determine the extent of injury, but really we just conservatively manage patients with strains and sprains with protection, rest, ice, compression, and elevation. So we call that PRICE. Shoulder dislocations. So I'd mentioned before that some patients with benign joint hypermobility and Ehlers-Danlos syndrome can actually consciously, voluntarily displace their shoulder. But for the most part, this is due to a traumatic injury. So patients can fall out outstretched. Anterior displacement is more common. If a patient has a posterior displacement, you got to check for neurovascular compromise because you got to worry about whether or not there's disrupting the brachial plexus or the arteries in the area. So the treatment is closed reduction. We don't necessarily send these patients to surgery. We just pop it back into place, put them in a sling. They have torn muscle ligaments in there, so you have to tell them to avoid activities until this can heal. Sometimes it can take 6 to 8 weeks. Physical therapy is important to preserve range of motion. Knee injuries. All right, the Pittsburgh knee rule. I don't know if you're familiar with this, but I'm going to go ahead and go over it. So this is the rule about when do you get an x-ray on a child who injured their knee. All right, so the rule is if there's a recent fall or blunt trauma under 6 days old and the child's under 12 years old or older than 50, or the child's unable to take 4 weight-bearing steps. Limping is allowed, okay? Now, they did a study and they validated this rule. In over 900 patients between the age of 6 and 96 years old, they found that the Pittsburgh knee rule, if you applied it to these patients and it's positive, 25% of patients will have a fracture. But patients who do not meet criteria for the rule, hardly any of them had a fracture, 99.7% specificity, negative evaluation, right? So this is actually a very helpful thing. So there are several types of different knee injuries, and it can range anywhere from patellar displacement, meniscal injury, collateral ligaments, okay? So patellar dislocation, I mean, this is pretty noticeable. The child's in pain, their knee looks funny. If you get an x-ray, you'll find that the patella is off to one side. There may be ligament laxity, shallow femoral groove, and some risk factors to this. And then the child will not let you touch their knee. They have a positive apprehension test. And so one of the ways to diagnose it, aside from an AP lateral x-ray, you get the sunshine review. So what it is you have the patient lay down, their knees flexed a little bit, and then you take an oblique angle x-ray. So it looks like the sun rising, okay? So the treatment of choice is closed reduction. Sometimes we'll do taping as well as a stability brace. Physical therapy is important. ACL injury, so the anterior collateral cruciate ligament, ACL injuries can be pretty common, particularly in female athletes. And this involves sports that are where it's high, fast, and then they stop, and then they start again, so it's like jerky motions. And so these athletes will say that they have a pop, and then followed by pain, swelling, and then they can't bear weight. So the most sensitive and specific test for ACL tear is actually the Lachman's test. This is when you have the patient lie down, and then you put one hand on their femur, the other hand behind the knee, and you do an anterior translocation here. You shift up. And if it's more than 2 millimeter anterior translation of the tibia on the femur compared to the contralateral side, that's a positive test. And surgical reconstruction is often needed in order to return the athlete to play. Then you have collateral lateral injuries. So you have the medial collateral lateral ligament, and then you have the lateral collateral ligament. So medial collateral ligament injury is actually pretty common, and this is typically due to a lateral blow right into the knee. This is a valgus stress. You can imagine where the femur direction is and where the tibia is, and it just pops this ligament. So the diagnosis is made by the examination. Patients are exquisitely tender, and the knee joint is actually very lax in the valgus maneuver. It's non-surgical treatment. Sometimes we just brace these children, do physical therapy, and they do get better. All right, let's look at prepatellar bursitis. The prepatellar bursa is located right above the knee, okay? And this is where there's inflammation, swelling, or redness. And typically it's because of a direct blow to the knee. So patients fall. We see this in volleyball players, soccer players, football players. We see it also in basketball players and wrestlers. So it's just like a bam. And so the management is actually conservative. If you see redness, you see that there's skin disruption, you have to think about whether or not this is infectious bursitis. So you might want to get a needle and aspirate it and make sure that there's no infection. Now, meniscal tears. So the meniscus is the cartilage between the femur and the tibia. It's used to provide cushioning. And usually these are injured when there's a twist. It makes sense, right? You just twist it and it rips the meniscus. Most of the time it's the medial meniscus that's injured rather than the lateral. And so the way you test for this in children is you have them walk like a duck. They squat down and trying to waddle, and they're going to have a lot of pain along the medial part of the knee. They can't do it. So management is conservative. If it's a large tear and patients are locking their knee, or if they have all of a sudden catching or giving out of the knee, then we recommend surgery for that. All right, let's look at the next question. 14-year-old girl, she fell from her trampoline and landed on her knee one day ago. She was brought in by her mother. Evaluation noted mild swelling and bruising of the knee. She's able to take 10 steps limping. Based on the Pittsburgh knee rule, this girl would need A, an x-ray of the knee, B, MRI of the knee, C, CT scan of the knee, D, surgery for internal derangement of the knee, or E, reassurance. Correct. The answer is reassurance. Now, had this child been 11 years old, then you go ahead and get the x-ray. Or had this child be unable to take 3 steps, you go ahead and get an x-ray. All right, let's focus your attention now on the female athletic triad. And there's a definition to these females who are athletes, and it's comprised of 3 things: energy deficiency, menstrual dysfunction, and a low bone mineral density. So when we talk about energy deficiency, typically we think about inadequate nutrition. This can be from an eating disorder, or perhaps the child could not afford a meal or it's not being fed. So we calculate energy deficiency based on how much energy is available. And the way you calculate this is you figure out the calories that they take in minus the calories they use. So the optimal energy availability is about 45 kilocalories per kilograms. So remember this number, 45 kilocalories per kilogram. But you have menstrual dysfunction and abnormalities in bone mineralization if energy availability is less than 30 kilocalories per kilogram. Menstrual dysfunction is probably the earliest symptom of the female athlete triad. So these patients, they have an intact reproductive system, but it's just not getting through. The hormones aren't. There's a suppression of the hypothalamic axis. They can have anovulation, luteal dysfunction, oligomenorrhea. So, you need to inquire about how many periods these children have who are athletes. Lower bone mineral density. So these low bone mineral density are found in girls who are not menstruating. And so lower bone mineral density occurs more commonly in those who are amenorrheic compared to those who are eumenorrheic. And they're at 3 times the risk for stress fracture as well as skeletal muscular injuries. So these are the screening test questions. You ask the child, are you worried about your weight? Do you limit or carefully control food intake? We used to think that this is only in girls who have eating disorders, but the prevalence of boys having eating disorder has really blossomed in the last few years. About 30 to 40% of cases are actually from boys who have eating disorder. So ask the patient, are they trying to lose or gain weight? Is there any history of eating disorder, like in mom or anything like that? Sometimes these children, there's a lot of peer pressure, like, oh my gosh, I can't believe you're eating that. That has 180 calories. So it's scary because you're like, you're an adolescent, you're still growing, you need the calories. And then you inquire about the first age of menarche and whether or not these patients have monthly menstrual cycles. How many menstrual cycles in the last year? If they have fewer than 6 menstrual cycles in the last year, that's a ding, ding, ding alert. And whether or not these patients have had stress fractures. So this evaluation should be part of your sports physical questionnaire, particularly in patients who are at risk, the female athlete who is underweight. Now, these patients may also have bradycardia, orthostatic hypotension, and you might look for signs of an eating disorder, such as dental caries, the fuzziness that these patients get. So rule out other causes of menstrual irregularity. Just because they don't have menstrual cycles doesn't necessarily mean that they have an eating disorder. And then identify metabolic disturbances due to eating disorders. Now, bone mineral density testing by DEXA, or dual energy absorptiometry, is indicated if the patient has an eating disorder, low body weight or BMI, if there's more than 2 stress fracture. So these are the indication for BMD testing. Know this, okay? If there's an eating disorder, low body weight, greater than 2 stress fracture, weight loss of more than 10%, menstrual dysfunction, again, the number is 6 menses, under 6 menses in 12 months, and a low energy availability for more than 6 months. So it takes a multidisciplinary team in order to manage these patients. You need a nutritionist, you need a psychologist, you need to have like a sports medicine doctor. It really is a team to try and get these patients to be as healthy as they can. And the goal here is to improve their energy availability to more than 45 kilocalories per kilograms per day. So that equates to about a minimal daily energy intake of 2,000 kilocalories. So this is very controversial. Estrogen replacement. And there's mixed results about whether or not estrogen can help with bone mineral density. And the thing about oral contraceptives or estrogen is that it can obscure the goal of returning menses to normal. So we have a hard time knowing whether or not the patient is back to having an intact hypothalamic axis that is working. These patients often require a higher calcium intake, 1,300 milligrams a day for 9 to 18-year-olds. Their vitamin D intake is required to be at 600 to 1,000 units a day. If they're low on vitamin D, and you check the 25-OH vitamin D, don't check the 125, but just the 25-OH vitamin D. If they're deficient, bump up the vitamin D intake to 2,000 units a day, or you can do D2, vitamin D2, 50,000 units once a week for at least 6 weeks, and then you put them on maintenance therapy. Vitamin D levels will not change overnight. So when you start somebody on supplementation, you need to wait at least for about 3 months before repeating the test, sometimes wait up to 6 months. We do not recommend bisphosphonates for these young patients who have low bone mineral density. And the reason why is because these patients are still growing, and bisphosphonate binds to bone. And the bisphosphonates would stay for a long time in their system. And so it prevents the resorption of bone and the proper bone remodeling in these patients who are growing. Let's talk about performance-enhancing substances. Do you all know who this is? Alex Rodriguez, yeah, exactly. And he's done some bad things in his life that cost him over $4 million in the Hall of Fame. And he's actually regretted and spoke out against performance-enhancing drugs. And so there's many different kinds of performance-enhancing drugs that athletes use, and not all of them are drugs, and that's why they call it substances here. But I want you to be aware of them because you need to be screening for this. So these patients may find sources of exogenous testosterone. There could be anabolic steroids. When I was growing up, it's primarily the anabolic steroids we hear about. And usually the steroids are used to increase muscle mass and strength, so these patients don't feel as much pain when they're pumping iron. Growth hormone has been used to increase muscle mass and decrease fat. Some of these patients result to erythropoietin so that they can increase the number of red blood cells and O2 carrying capacity. So Lance Armstrong, so he's basically accused of doping, so with erythropoietin. He also apparently had donated his own blood and then stored it and then would reinfuse his own blood before races, supposedly. He doesn't admit to it. Stimulants, this is to suppress the appetite, increase alertness. Diuretics can be used to lose weight in order to get to the weight category, so they want to compete at a lower weight level, particularly in weightlifting or in combat. But diuretics is also used to dilute urine to mass banned substances. Some of these patients will also use laxatives. Now, the thing about performance-enhancing substances is that it can cause a lot of side effects. These patients may not understand it. I mean, they're young, they think that they're going to be the best they can be and going to beat all their classmates, they'll beat all their competitors, but you have to tell them and counsel them that sometimes these drugs can cause high blood pressure, ventricular remodeling. Some patients can have myocardial infarctions, arrhythmias. They don't grow, they have shortened stature, testicular atrophy, decreased fertility, libido. In females, they may lose their hair and have a male pattern baldness, voice changes, and also sudden death. So these children do not realize the implication that goes along with performance-enhancing substances. But one of the first things that parents notice is the change in behavior. So these children may be very violent or aggressive, severe mood swings. You screen for drug use. And I think you'll have a lecture on drug use later. All right, so here's the next question. Which of the following comprises of the female athlete triad? Is it A, menstrual dysfunction, depression, and low bone density? B, menstrual dysfunction, low energy availability, and low bone density. C, bulimia nervosa, menstrual dysfunction, and low fat index. D, anorexia nervosa, low body fat index, performance drug use. E, any eating disorder, depression, and overexercising. Your answer, please. It is correct. B is correct. So it has to do with menstrual dysfunction, low energy availability, and low bone mineral density. So mood isn't part of this. We don't measure body fat index, and we don't ask about performance drug use. So, and this one, again, mood is in here. Over-exercising is part of the eating disorder. So the correct answer is B. All right, so for the last few minutes, what I'm going to do is go through the high-yield pearls. These are buzzwords that you have to keep in mind when you're approaching the board question. Our first one is, remember, congenital torticollis is an injury to the SCM, sternocleidomastoid. The second one is, if you see clubfoot or skiffy, refer to orthopedics. Most cases of in-towing, it's managed conservatively, and they will resolve spontaneously by school age. Klippel-Feil syndrome, think about short neck, limited neck motion, low occipital hairline. And thoracic scoliosis greater than 50 degrees can cause PFT abnormalities. At 25 degrees or more, if there's rapid progression, these patients need to be referred for bracing. Scheuermann's kyphosis is anterior wedging of more than 3 thoracic vertebrae. And then developmental dysplasia of the hips, more common in females, firstborns, breech position, infants with a history of intrauterine crowding. This requires surgical evaluation. Barlow and Ortolani maneuvers are used to check developmental dysplasia in newborns and in children under the age of 3 months. Use the Galeazzi test to check for hip dysplasia in 8 to 10 weeks of age. And then osteoid osteoma, remember these are prostaglandin-producing lesions, severe nighttime pain that responds to aspirin or NSAIDs. Growing pains aren't due to growing, they're bilateral, rule out the red flags. Legg-Calvé-Perthes disease is avascular necrosis of the femoral head in boys 3 to 12-year-olds. You also require surgical evaluation. Slip capital femoral epiphysis, that's the ice cream falling off of the cone, usually in obese boys. Adolescents get an x-ray. Sever disease, this isn't severe disease, it's sever disease. This is pain at the calcaneal growth plate, usually in repetitive sports. And then remember PRICE, which is protection, rest, ice, compression, elevation for sprains and strains. And then we have patellofemoral syndrome. This is the most common cause of anterior knee pain in the young athlete. Osteochondritis dissecans, this is your joint mice, and it's basically cartilage and bone pieces breaking off. Spondylosis is degenerative joint disease. Spondylolisthesis is spontaneous subluxation of one vertebra over the other. Then you have spondylolysis, which is fractures of the par. So these spondylo are what will confuse you, okay? The Pittsburgh knee rule, remember fall blunt trauma and age less than 12 or unable to take 4 steps. Limping is allowed. That's when you get the x-ray. The female athlete triad, that's where there's energy deficiency, menstrual dysfunction, and low bone mineral density. And you got to maintain vigilance for performance-enhancing substances. I want to thank you, and I'll take any questions. Thank you.